So you see your life because you started recording, so you want us to continue. You don't want that one to be part of the recording. Okay, let's move on. Well, first of all, talking about the cutaneous leishmaniasis. As I said earlier on, it is self-limiting. So at the end of the day, the wound can get healed by itself. So within a week or two, then antibodies should be produced. Antibodies should be produced, and then this will help with the healing of the wound. Now let's take note of this. The urban cutaneous leishmaniasis is thought, please. Who is that? That. Ah. Mabel, I'm trying to mute you, but your thing is not muting. You have a lot of noise at your background.
Madam, I'm not the one. You are just giving me false accusation.
Okay. All right. So with the cutaneous, because it is at the among people who dwell in the cities, it is believed that it can be transmitted from human to human, right? Which is the anthraponosis. But with the rural one, definitely the major host now will be the sandfly. I don't know if you are getting the explanation.
Yes.
With the cutaneous, it is believed that if one human being gets it, it can give to the other. Because the sandfly is not common in cities compared to those in the rural settings. So with the rural cutaneous, we can confirm that it is from the sandfly to man. But with the urban cutaneous, you say that it can be transmitted from one human being to another. So with the clinical symptoms, the first one is the presence of the red purple at the site of bite. Then once it is there, you feel, once you are being bitten, you feel itchiness. So as you scratch, as you get irritated and then you scratch, you realize that you are creating wound on the surface of your skin. And with time, it can get enlarged and then ulcerate. So in this case, to both the humora and then the humora, for that one, there's for sure. And then the cell-mediated immunity are involved. The first point of contact is even when the sandfly bites, immediately you realize that something has bitten you. So you even try to kill the sandfly because you feel the pain. Then you start scratching before antibodies will end up being produced at the end of the day to protect you. So these are some of the treatment drug of choice. Then, as usual, prevention. You try to handle the sore, which is the ulcers, and then the sandfly, which is the reservoir. Then the last one is the mucocutaneous leishmaniasis. With the mucocutaneous, the reason we are calling mucocutaneous is because
Madam, there's an interruption, madam, please.
Okay.
You see the first one you mentioned, not the cutaneous, where the first one that happens to the liver, the liver and the spleen that gets swollen. You did mention some drugs, okay? And then the drugs you've just mentioned with the one with the cutaneous is like, there are some similar ones in there.
Yeah.
My question is, now this is cutaneous and that one is like internal, right? What are the mechanisms behind those drugs?
Which
and
drugs?
How do they work? The ones we use for the treatment.
As in how they get to their target site?
Yes, and then how they interfere with the processes to stop the
That
inflammation.
is pharmacology for you. I'm not teaching you pharmacology.
No, but
Nathaniel.
madam, at least you should give us an enlightenment that this is how the disease interferes so that we are aware. So when this will be the side effect. So when we are prescribing, we know what we are.
If you want side effects, please, this is microbiology, not pharmacology. So if you want to know, please, you can go and read more on that. And let's take note. The reason why, when it comes to the drug, I don't emphasize more on it is because every country has its own drugs of choice. So the standard of I've forgotten the term. There are standard guidelines for each treatment for each country.
And then, madam, there are policy guidelines on treatment.
Yes. So some of the drugs that I list may not necessarily be within the Ghana Health Service guideline. And I know every hospital has that book. Every consulting room has that book.
The book is called Standard Treatment Guidelines.
Yes. Thank you.
Madam, thank you.
You see, so that is why I don't put much emphasis on this is microbiology. If I pharmacology class, I can be able to explain myself further. But this is microbiology. I don't want to put someone's job into mine. Where it is necessary that I have to point it out to you, I will let you know. So when you're talking about the production of antibodies, so the antiretroviral drug, for that one, I may be tempted to go deeper if I want. That one to be my choice to decide to do it or not. If not, this one is just microbiology, which has got nothing to do with pharmacology. Are you okay?
Okay.
Madam, please, microbiology is not just, and for them, give them, when the pharmacology class starts, they can ask their questions. So let's continue so that we can complete the further with the next class.
Hey, you people, so the just so you have decoded it.
Who is that talking? Who is talking?
Let's move
Mention
on.
your name.
Okay, so the reason with the mucocutaneous, it's both the skin and then the mucous membrane. The etiological agent over here is Leishmania brasiliensis.
Madam, please, you said it affects both the skin and the
mucous membrane.
Okay, thank you.
Okay, so it is here. Some strains affect the cutaneous tissue, and then others the mucous membrane. So the mouth, the nose, the pharynx, you know that, right? And then some can be disseminated through the lymphatic channels. Let's take note. With the visceria, it's through circulation, through blood. But with the mucocutaneous, talking about the lymphatic channels. Occasionally, will you see them through the bloodstream, right? Okay. With the pathogenesis, we saw this earlier on, that the promastigot is injected. Then within 1 to 4 weeks, there'll be appearance of papules, which can heal within 6 to 15 months. Take note of the duration. We said earlier on that they are self-limiting. That means they can heal by itself. However, with the duration 6 to 15 months, who will be happy to have the wound ulcer on their body from month 1 up to 15 months? It can be so. So there definitely has to be intervention. That is where there are treatments for them. Okay, so the lesions are confined to the mucous membrane, the cartilages, and then the skin. Okay, now once you are having a wound which refuses to heal, definitely it calls for other microorganisms. You know, bacteria has affinity for wound. So definitely Staph aureus, which is on your skin, will make the wound its home. Are you with me? And once other infection sets in, the rate at which the wound heals decreases. So with the laboratory diagnosis, you can culture and then do your isolation. You can do your PCR. You can do the antigen antibody as well. So this is an image of the ulcer that we are talking about. So the prevention is just the same. You treat based on the presentation, and then you as well clear away the parasite, in this case the sandfly. Next on the line is Plasmodium. For this one, it's our friend, is with us. As we are speaking, many of us are carriers of Plasmodium. We are carrying.
I live in a residential area.
Pardon?
Forgive me, I live in a residential area, so there are no mosquitoes over here.
You are deceiving yourself. What you are saying is a deceit. Benson.
Yes, madam.
What you are saying is a deceit.
Okay, madam.
Right now, as you are speaking, maybe one of them is even biting you. Okay. So talking about Plasmodium, we have 4 species: Falciparum, Vivax, Ovale, and then Malaria. With us in Ghana, the most common one is Falciparum, right? In certain instances, you see the Vivax. I think few cases, and then the Malaria. So what normally happens is, let me give you the summary of what happened so that we don't spend so much time on it.
Madam,
so
please, I have a question.
Okay.
In some literature, they point out the 5th one, which is the Knowlesi. I don't know.
Yeah, Knowlesi. Yes, there is Knowlesi, but it's not common among us here. Then you have to mention a Knowlesi.
Okay, madam.
Okay. So now, mosquito, which is the vector, comes to us every now and then because we make room for them to grow. They come to take a blood meal. And as they are taking a blood meal, they are injecting sporozoids. So the sporozoids will move through circulation straight to the liver. It has affinity for the liver cells. Why do you think they strive within the liver? You know, almost all the parasites I'm talking about, I keep mentioning liver cell, liver. Why do you think so?
Because they can hide it.
Why do you,
Madam, the iron.
The liver cell has hepatocyte cell. The liver cell has 4 liver cells. They have the hepatocytes. They are able to stay at the hepatocyte side of the liver because they are able to feed much over there, much on the red blood cell over there before it comes into the bloodstream.
That is not what I'm looking for.
Madam.
Yes.
Madam, they feed on the iron. Madam.
No. The iron is erythrocytic stage.
Madam, I think the liver, because the immune system can't fight the liver.
It has less amount of white cells.
Oh, okay.
So they go there and then hide there because they know that they are trying to dodge the white cells.
Okay.
Okay. So they go straight to the liver. Over there is a little bit of freedom, so they can hide. They won't see them. And now, you know, where they go, the word is hide, they get sequestrated. Sequestration. That's the scientific term. But for the layman, they go and hide there so that the white cells will not see them and then start engulfing them. So they will be there for some time. Then, within 30 minutes, as the slide is saying, so they will divide to form schizones. Now, these schizones will then move to the red cells. So at the red cell level, the process that is ongoing there, we call it the erythrocytic schizogony phase. Someone has sent a chat. Elisha, how do you mean power of Google?
Madam, I was referring to the literature aspect of Jeff.
Okay, please, if you know the chat is not for me, don't put it there, because it will be giving me signal that I have a chat. Now, so with the erythrocytic phase, the schizones as well will burst to release merozoites. These merozoites then invade the red blood cells. Now, once the red blood cells are invaded, they go in there to divide, they feed, right? So with that, they canalize the red blood cells. That is what is responsible for the anemia you see in malaria. Now, with the P. vivax and P. ovale, some of the divided cells in this case, the merozoites, can go back to reinfect the liver cells. But with the falciparum and then the malaria, for those ones, once they invade the RBCs, the merozoites don't go back to reinfect the liver cells again. All this is, most of them are for literature, so I won't bother you much on it. But what you know is that, what you need to note is that we have the liver stage and then the erythrocytic phase. Now, so with the erythrocytic phase, the merozoites then destroy the red cells, as I mentioned. Lymphocytes matures to form the gametocytes. So when another mosquito comes for blood meal again, they pick the gametocytes, which they go to use to fertilize. So the gametocytes within the midgut of the mosquito will grow and then divide to form the sporozoites for the cycle to continue.
Madam, please, I have a question.
Okay.
Madam, please, the gametocytes. The gametocytes, it can be male or female. So
yes,
in case the parasite takes the malaria, takes maybe the male part of it, would it be able to transmit that same malaria parasite, or unless it takes the female, that's when they can transmit it?
Pardon?
The gametocyte, it has the male and female parts. My question is that the malaria, when it comes to maybe feed on the blood, and maybe it gets to take in the male part of it, will it be able to transmit the malaria parasites, or unless it takes the female? Because I know it's only female Anopheles mosquito whereby they will be able to transmit the infection. I just want to be clear about that, please.
I'm trying to get your question. What I know, okay, let me say, maybe what I can deduce from whatever you are saying. Okay, I'm thinking that your question could be that when it feeds the male gametocyte, will it be able to go and fertilize the egg?
Exactly.
Within the,
yeah, sure, something like that. Yeah, yes, madam. Yeah.
Hey, look at how you are telling though. Okay. So the mosquito has what? What does the mosquito have and not waiting for the gametocyte to come? Hello.
Madam.
Hi.
But my question is, the mosquito coming in, it might be a male or a female, and it's coming to take the mature.
The mosquito that is coming for the blood meal.
Yeah,
okay,
sure.
Okay. If it is a male mosquito and then coming for the gametocyte.
Yes, please.
Will it go and then?
Supposing it takes the male part of the gametocyte, or maybe it takes the female part. My question was that if it takes the male part and transmits it to another person, will still the malaria infection will still take place? Or unless it takes the female part, that's when the infection comes.
The male mosquito cannot undergo Mucocutaneous, right? Because it is male. So that's why we say it's the female Anopheles that can transmit. So if it is the male one that is coming for it, then the cycle truncates.
Okay.
Hello.
I'm getting.
Madam, I think his question is that since the mosquito will be taking the gametocytes.
Which of the mosquitoes? Because he's talking about male and female.
The mosquito that has bitten you, the female Anopheles mosquito has bitten you.
So you are saying female, but he is saying male.
Madam,
I was trying to explain the question.
He's trying to explain my question. Let's say a female comes to take the male part of the gametocyte.
That is, but
will they be able to transmit it?
It's good.
The same way, like
one at a time, so that I can get you.
Madam, the question is, if maybe a female Anopheles mosquito comes to take the gametocyte of the parasite and sends it and infect another person with it, that's the male part. Would that person be able to manifest that same symptoms, like let's say a malaria infection, or let's say if it takes maybe a male Anopheles mosquito comes in to take the male part or maybe a female part, would that still transmitting still go on?
Would the cycle still continues?
The
or
point
the
is,
presentation as
the male
malaria?
and the female part, does it have maybe an infection or maybe transmitting of the malaria parasite, the male or female part of the gametocyte? Does it play a major role on infecting or the person getting infected?
I don't get you.
The thing is simple. Madam doesn't understand the question. Skip the question. But stop. Let's continue. Madam, continue.
Madam, let's continue. It will come.
Okay. Maybe if you can send me the chart, maybe when I read, I can understand. Because your line is breaking.
Yes, madam.
Okay, so let's go through the diagram. We have mosquito taking the blood meal. Someone has sent a message. Yes, I'll go through the cycle once again. There's a diagram here, so don't worry. So mosquito for blood meal, in the process, injecting sporozoites. Sporozoites move to the liver cells. Over there, mature to form schizons. Schizons ruptures, then releases merozoites. This moves into RBCs. Now, within the RBCs, they divide to give out the trophozoites. The first trophozoites are the ring stage of the parasite. Then they mature within the red cells to form the schizons once again. The schizons rupture, to release their contents. So we are saying that their contents which are merozoa. You are saying in the case of P. vivax, they can go back to reinfect the liver cells. But what we're interested in the falciparum, which is common among us, those ones, they grow into gametocytes. The gametocytes are male and female. So we just call them the macro and then the micro gametocytes, male and female. The male and female is immunology down there. So, but the name is just gametocytes. So now the next mosquito comes for blood meal. And then in the process of taking the blood meal, picks the gametocytes. Right? Then within the guts of the mosquito, the gametocyte that has been picked will go and then grow and then fertilize the egg of the, how do you call it? The egg already waiting in there within the guts of the mosquito. Will go in there and then undergo the process that we are calling the ookinesis. The ookinesis will yield the oocyst. This oocyst is just sporozoites that are in a cyst, or eggs that are in a cyst. Who is that? So when this cyst or when a cyst bursts within the guts of the mosquito, as it's going for the new blood meal pickup, the sporozoites are there within the saliva. So as it's taking the blood meal, it can inject the sporozoites back to man for the circle to continue. Have you sent a chart now? There is no chart here.
Madam.
Yes.
I want to ask, the vivax going back to infest the liver, has it got something to do with recurrence of the disease after treatment?
Yes.
Even if you stick to the dosage regimen?
If we stick to the dosage regimen, with vivax, we know that some of them can hide. So at the end of the day, it can go back to reinfect. But okay, I've seen your question. I'll go through and then answer you. But with the falciparum, it will not go back.
So, madam, has it got something to do with, that means the choice of drug for treatment too matters?
Yes.
Okay.
And don't forget, they are developing resistance every now and then.
Okay, madam.
Okay. Okay, so Benson, your question. Madam, please, does the gametocyte stage of the male and the female play a role in transmission, just as the female mosquito transmission? Yes. Does the male and female gametocyte has any restriction when it's transmitted by male or female? So the first part of the question, I'm getting it, but the second part, has any restriction when it's transmitted by a male or female? How? Please, I don't get the question. Okay. Talking about the falciparum, let's look at how prevalent they are in terms of disease. That's malaria. So P. vivax and then malaria are the most common ones.
Hey. Oh, my friend, come and sit small. Come and sit small so that I can go. Maria, come and sit down
Esther.
small.
Esther.
Even Amelia, you people. So you see, they'll do this, then they'll come back and say, Madam, I don't understand. Explain again.
Madam, forgive them.
Okay. So from what you're saying, Plasmodium is the most common one among us here, followed by Vivax and then Malaria. Ovale is what? Rare, as well as the Knowlesi. So clinical symptoms of malaria, these ones, you know them, right? They are with us, so we know even you yourself, you'll be experiencing them. So the rise in temperature as a form of inflammatory response, anemia because of the lysing of the red cells. Then some of them photophobia, fear of light. Then if the parasite is able to move into it's able to cross the blood-brain barrier, it can result to cerebral malaria. You see the enlargement of the liver and the spleen because they play a major role in Plasmodium infection. The gold standard is microscopy, not rapid diagnostic.
Madam, please, splenomegaly. Does it happen to only children or adults too?
It's normally pronounced in children, but adults too, you can say that.
Madam, please, can you go to the previous slide? The gold something. Madam, what does it mean?
The gold standard is microscopy, not rapid diagnostic testing. That means that if you really want to see if the parasite is within the blood, the best thing is you do microscopy. And even that, please, let's take note of this. Thanks for reminding me. You know, some people can come to the hospital and be presenting with the signs and symptoms of malaria, right? You do your RT and then you don't see anything present. You do your if you do RT, you don't see anything present. And then the RT, it could be that the parasite concentration is very low, so you don't see it in circulation. Microscopy to the same thing applies. It's either you yourself, you are not that good with the microscopy, or they are so small in quantity, so you can't see it. But it does not mean the person does not have malaria. It could be that it is at the liver stage. So it's not yet in circulation.
Madam, please, sorry to disturb you. Sorry to cut you. Let's not forget malaria pigments. Under the microscope, you still find malaria pigments in the white blood cell. They are a bit brownish in that way. So
yes,
in pathology, when you see malaria pigments or something that comes about with the infection, you still have to report it as positive. So the malaria pigment is also another factor one has to consider when maybe you don't see tophozoites or any parasites in there.
Yes. So even before you even talk about the malaria, if it's not moved to the erythrocytic stage, there's no way you see it because it's not in blood. But at the liver stage, the pre-erythrocytic stage, they are hiding over there. And over there, the only thing you can use is if you do your differential of white cell count. And in that case, which of the white cells will be dominant? Answer me now. The lab guys.
Okay, lab.
Madam, those that detect parasites.
Which one are those?
Madam, eosinophils and basophils.
Yeah, so you're likely to see a lot of basophils.
As granulocytes. Granules.
Yes.
And we don't use the buffer too. We don't use the malaria buffer. Sometimes there is also another factor. That's why we don't get the parasites in there.
Why would you use the buffer? How will it move?
That means some facilities, they don't have the buffer. They just use the normal germicide and stuff. But when you add the buffer, you're able to identify stuffs in there. The correct morphology of the trophozoites and the pigment.
Interesting.
Yeah.
We are in the hands of God. That is Ghana for you. The lab guys are saying that they don't use buffer. Okay.
Madam, with the RDT.
Okay.
Talking of the various types of Plasmodium species that we have, is he able to detect about 3 or 4 of them? Let's say the prevailing ones in Africa or Ghana.
Mm-hmm.
Is the RDT, when you do the RDT for malaria, is he able to detect about 3 or 4?
Yes, we have some strips that are able to detect. They write it on it. Those strains that the RDT will be able to pick.
Oh, okay.
But for you to be sure, that's what I said, for you to be sure, the best standard is microscopy.
Okay, madam, please. Madam, please, you are talking about the fact that even if you do the microscopy and then you are still not seeing anything, but the client is presenting with clinical features or signs that the person has malaria, you still go ahead to treat malaria. But then the policy guideline on treatment.
I didn't say you still go ahead and treat malaria.
Oh, okay.
Madam, please, why is it that most of the times?
Hold on. I said you can do your differential white counts to buttress your points. So if you know that malaria is endemic in the area and counts with such symptoms, by the end of the day, because it's not in circulation, you can't get it. Then you do your differential white counts. Then if you confirm that it is malaria, then you can go ahead and do your treatment.
Oh, okay, madam.
So who was talking?
Madam, I was talking. Why is it that most of the times patients with malaria have high platelet counts?
High
platelet count.
What's the function of platelets?
Clotting.
Or clotting.
And what